the improvisational oncologist. The bone marrow biopsy took about 20 minutes. It was 10 o'clock on an unusually chilly morning in New York in April, and Donna M., a self-possessed 78-year-old woman, had flown in from Chicago to see me in my office at Columbia University Medical Center. She had treated herself to orchestra seats for the humans the night before, and was now waiting in the room as no one should be asked to wait, pants down, spine curled, knees lifted to her chest, a grown woman curled like a fetus. I snapped on sterile gloves while the nurse pulled out a bar cart containing a steel needle the length of an index finger. The rim of Donna's pelvic bone was numbed with a pulse of anesthetic, and I drove the needle, as gently as I could, into the outer furrow of bone. A corkscrew of pain spiraled through her body as the marrow was pulled, and then a few milliliters of red, bone-flecked sludge filled the syringe. It was slightly viscous, halfway between liquid and gel, like the crushed pulp of an overripe strawberry. I had been treating Donna in collaboration with my colleague Isra Raza for 6 years. Donna has a pre-leukemic syndrome called myelodysplastic syndrome, or MDS, which affects the bone marrow and blood. It is a mysterious disease with few known treatments. Human bone marrow is normally a site for the genesis of most of our blood cells, a white-walled nursery for young blood. In MDS, the bone marrow cells acquire genetic mutations, which force them to grow uncontrollably, but the cells also fail to mature into blood, instead dying in droves. It is a dual curse. In most cancers, the main problem is cells that refuse to stop growing. In Donna's marrow, this problem is compounded by cells that refuse to grow up. Though there are commonalities among cancers, of course, every tumor behaves and moves, thinks, even, differently. Trying to find a drug that fits Donna's cancer, Raza and I have administered a gamut of medicines. Throughout all this, Donna has been a formidable patient, perennially resourceful, optimistic and willing to try anything. Every time I encounter her in the clinic, awaiting her biopsy with her characteristic fortitude, it is the doctor, not the patient, who feels curled and small. She has moved nomadically from one trial to another, shuttling from city to city, and from one drug to the next, through a landscape more desolate and exhilarating than most of us can imagine. Donna calls it her serial monogamy with different medicines. Some of these drugs have worked for weeks, some for months, but the transient responses have given way to inevitable relapses. Donna is getting exhausted. Her biopsy that morning was thus part routine and part experiment. Minutes after the marrow was drawn into the syringe, a technician rushed the specimen to the lab. There he extracted the cells from the mixture and pipetted them into tiny grain-size wells, 500 cells to a well. To each well, about 1,000 in total, he will add a tiny dab of an individual drug, prednisone, say, to one well, procarbazine to the next and so forth. The experiment will test about 300 medicines, many not even meant for cancer, at 3 different doses to assess the effects of the drugs on Donna's cells. Bathed in a nutrient-rich broth suffused with growth factors, the cells will double and redouble in an incubator over the course of the following 2 weeks, forming a lush outgrowth of malignant cells, cancer abstracted in a dish. A computer, taught to count and evaluate cells, will then determine whether any of the drugs killed the cancerous cells or forced them to mature into nearly normal blood. Far from relying on data from other trials, or patients, the experiment will test Donna's own cancer for its reactivity against a panel of medicines. Cells, not bodies, entered this preclinical trial, and the results will guide her future treatment. I explained all this to Donna. Still, she had a question: what would happen if the drug that appeared to be the most promising proved unsuccessful? Then we'll try the next one, I told her. The experiment, hopefully, will yield more than one candidate, and will go down the list. Will the medicine be like chemotherapy? It might, or it might not. The drug that we end up using might be borrowed from some other disease. It might be an anti-inflammatory pill, or an asthma drug. It might be aspirin, for all we know. My conversation with Donna reflected how much cancer treatment has changed in the last decade. I grew up as an oncologist in an era of standardized protocols. Cancers were lumped into categories based on their anatomical site of origin: breast cancer, lung cancer, lymphoma, leukemia, and chemotherapy treatment, often a combination of toxic drugs, was dictated by those anatomical classifications. The combinations, adriamycin, bleomycin, vinblastine and dacarbazine, for instance, to treat Hodgkin's disease, were rarely changed for individual patients. The prospect of personalizing therapy was frowned upon. The more you departed from the standard, the theory ran, the more likely the patient would end up being undertreated or improperly managed, risking recurrence. In hospitals and clinics, computerized systems were set up to monitor an oncologist's compliance with standard therapy. If you chose to make an exception for a particular patient, you had to justify the choice with an adequate excuse. Big Chemo was watching you.